to talk about diabetes, and this is a huge subject. And what I'm going to do today is I'm going to try and give you a framework in terms of how to approach management of diabetes and some updated information in terms of macrovascular complications of diabetes. There's just simply too much to cover, but what I'm talking with is a group of primary care docs, so this is oriented towards what the primary care doctor is going to be seeing in the office. I will not be talking at length about type 1. I will not be talking about insulin. I'm going to be talking about diabetes issues that you all are seeing in the office, by far the most common problems that you're seeing. And as you're all aware, diabetes is a huge issue in this country and is becoming a bigger issue as time goes on. Overall prevalence of diabetes, we're looking on the order of around 5%. That's known diabetics in this country. There are a lot out there that aren't known. This doesn't factor in pre-diabetes, which is a whole different subject. So this is a very big issue. And of course, the problem here is that it's becoming more of an issue in the older individuals, the baby boomers. This is where we're seeing our diabetes now, particularly type 2 diabetes. It's NHANES data, it's old data, but it still holds. You can see that the brunt of diabetes is happening in older individuals, and it's mainly type 2. Now, why is this happening? I think it's pretty clear in terms of the obesity epidemic. I'll have a word about in a moment. But these are staggering numbers, and as the baby boomers move up, we're going to be seeing more and more of it in our office. Currently, about 1 in 5 Americans beyond the age of 60 have diabetes. The prevalence is much higher in older individuals compared to those who are younger. It's disproportionate. We're seeing it in blacks, Hispanics, in the American Indian population, the Pima Indian population down in the Phoenix area where I am. Virtually 100% of them have type 2 diabetes. Internationally, this is not a problem confined to this country or Canada. Internationally, diabetes patients over the age of 60 are 2/3 of all diabetics. And this is particularly true in developing countries. As prominent and as prevalent as it is here, think of India, think of China, with the populations they have over there. As those populations are becoming more westernized and more sedentary and more obese, diabetes is taking off in those countries, and particularly in China. Health agencies over there have a crisis on their hands in terms of the numbers of diabetics and the problems associated with it. Worldwide, in 2000, prevalence of diabetes is around 3%. That's expected to probably double by 2030. And again, we're seeing it in developing countries. So it's not unique to here. This is a worldwide epidemic and worldwide problem. And of course, the costs are fairly staggering. These are old numbers now. I think you're all familiar with the costs that come with diabetes. The average medical dollar, much more of it is spent on a diabetic than on a non-diabetic. So there are not only morbidity, but there are health costs, significant costs associated with this condition. And this is, David was recently here. He's since been returned to Italy, and he had a little bit of a problem when he's over here. I have to thank our proud sponsors for this. And I think it is safe to say that our society clearly has a problem. And again, it's not unique to America, although we're one of the most obese countries in the world. Developing countries are noticing this as well. And this, of course, is all part of the metabolic syndrome. Now, I won't go into the metabolic syndrome today. I just simply don't have enough time. But this is a presence of diabetes or prediabetes, history of hypertension, high triglycerides, typically low HDL-C, increased waist size, and it all comes back to this. And I think if anybody has the answer to this, not only are you going to retire early, but you're going to do a great service to mankind. Obesity underpins virtually all type 2 diabetes mellitus. So having put all that forth as an introduction, how do we approach treatment of diabetes? And what I'm going to give you is a compilation of how we approach diabetes as an institution, how many other institutions are approaching it, and how this all factors in with what the American Diabetes Association feels about it. But if there's one message I want to give you right at the outset in terms of managing diabetes, it's this: the importance of the diet, first, last, and always. I can't highlight enough how important the diet is in terms of managing all diabetics, be it type 1 or type 2. And it's not this kind of diet. You've all seen this before over and over again. Doc, I use my diet drinks, and then you're loading up on all of the desserts. There are a number of things I want to point out to patients when I see them is that diabetes is going to get you sooner or later. One of the complications are going to pile up. And we cannot control it without a diet. Nothing works. Oral agents don't work. Insulin doesn't work. And in fact, if I take a diabetic who's not paying attention, not following a diet, put them on insulin, I'm not going to do anything for their blood sugar. All I'm going to do is make them more obese. We see this over and over again. So the diet really underpins what we're doing. And if there's one thing I've learned through the years in working with diabetics and their diets, and this fellow's looking for a 24-slice toaster, it's this. Go to your dietitian and keep it simple. There is not one diabetic diet plan that suits all diabetics. I think back, and some of the older people in the audience may remember the old exchange programs. To this day, I do not understand how those things worked. I never could figure it out, and patients certainly couldn't figure it out. Now we have dietitians. A trained diabetic dietitian may do nothing more than simply take an 80-year-old with diabetes who's a little infirm and try and get them to get the sugar out of their diet. Whereas a younger type 1, these individuals are taught how to count carbohydrates. They're taught how to adjust their insulin for X number of grams of carbohydrate. So there's a great span in terms of what we can do with the diet. And the dietitians are in our back pocket. They're my right-hand person in terms of managing diabetics. Enough about diet. It is important. I don't know the details of most of the diets. I leave that with my dietitian colleagues. But once we see a new diabetic, what do we do with them? Number one, refer for education, both diet and diabetes education by a diabetes educator who will then start them on self-home blood glucose monitoring. We will check the eyes, particularly in a newly diagnosed type 2, off to the ophthalmologist. They could have had their diabetes for many years and could already have retinopathy. The importance of assessing for other cardiovascular risk factors, very important. Dr. Basil's already talked to you about hypertension and how important that is. I'm going to highlight some of this with hypertension, lipids. You'll see shortly that there's more to a diabetic than simply blood sugar. Cardiogram, we get on most that are started right at the outset with their diabetes. I'll have a word about that in a moment. And if there's no contraindication and they're over the age of 40, the current recommendation is start them on aspirin immediately. And that we do subscribe to. Now on to therapies. And here's where things get kind of interesting because as primary care docs, you have a host of plethora of drugs that you can pick and choose from. And I've listed some of the oral therapies here. And we categorize these, as I'll show you the importance of this in a moment. When you look at the insulin secretagogues, we've got the old sulfonylureas that you're all comfortable with. Every one of us has used these. Put the generic and the trade names over there. The glinides, which are kind of a form of insulin secretagogue. The two that we have available, probably a lot of you have used. We have the biguanides, of which there's only one available, that being metformin. The TZDs, Rosie and Pile. Rosie is effectively gone, and I suspect in the future Pile will be gone, not too distant future as well, but nevertheless, we still have a TZD out there. The alpha-glucosidase inhibitors, you got a couple of those. You got these things called incretins that I'm going to talk to you about. You've got these things called DPP-4 inhibitors. We've got other medications. Believe it or not, bromocriptine is approved for treatment of diabetes, the stuff we use for prolactin-secreting pituitary tumors. Colicevalam, an old standby that's been around for a long time, also approved for treatment of diabetes. I've never used either of these. I have no idea. They did get approved. I guess they lower A1C. But these are some of the lists of medications that you get to pick from. And then you got combination therapies. And there are too many of them. I can't keep track of all the combination therapies there are out there, so I don't list them because they constantly change and there's too many of them. You all have seen, you've all been approached by the drug company with my combination's better than their combination. And then, of course, if all else fails, you got insulins, and I'm not going to go into insulin today. That's a whole separate issue, but there's just too numerous to mention to put it up there. And maybe in the question period, if insulin comes up, I can go over it, but I'm not going to comment about insulin. So with all this plethora of drugs out there, all of these tools that we have available to manage, what do you pick? When do you pick it, and why do you pick it? And a kind of a way of approaching this is go to the physiology. What causes hyperglycemia in a type 2 diabetic? And it's not a simple issue. There are a number of factors that lead to hyperglycemic in a type 2. Number one, that pancreas is not working properly. In the vast majority of obese type 2s at new diagnosis or even into their disease process, if you measure their insulin levels will be high. They are insulin resistant. But the point is that the insulin is not high enough to bring the blood sugar down. So by the time of diagnosis, there's already a problem with the pancreas. It's not able to make enough insulin to bring that blood sugar down. Moreover, as that diabetic progresses through the disease process, the beta cells eventually begin to fail, and sooner or later you can't put any insulin out of that pancreas. The natural history of type 2 is such that beta cell failure eventually will occur, and sooner or later, just about all type 2s will end up on insulin. But the point is that the pancreas, right from the get-go, is impaired. It's not working properly. There's a problem with the liver right from the get-go. In a normal individual, as insulin comes out, this will shut down hepatic glucose production. At the level of the liver in a type 2, they're resistant to that insulin. The hepatic glucose production is not shut down, and the liver is actually contributing to the hyperglycemia because of insulin resistance at the level of the liver. At the level of muscle, you're all aware of peripheral insulin resistance, which occurs in a type 2. Well described and a very big issue. And now we're more recently becoming aware of how important the gut is in terms of managing and causing hyperglycemia. In terms of diet, these things called incretins, the GI tract actually has tremendous influence in terms of hyperglycemia in a type 2. So these are kind of all the multifactorial issues that we need to consider when we're looking at what causes hyperglycemia in that individual. So in terms of management then, what can we do? Well, we can flog the pancreas. We can give these things called insulin secretagogues. You've got that previous list. We can hit that pancreas to try and produce more insulin. They work, and they work well, reasonably well. Alternatively, we can hit the liver. Let's try and sensitize that liver to the insulin that's out there so that we can reduce hepatic glucose production. We can hit the muscles. TZDs will do that quite nicely and enhance peripheral insulin sensitivity. It reduces insulin resistance, the level of muscle. And when you look at the level of the gut, we've got these things called incretins again, the DPP-4 inhibitors, and the alpha-glucosidase inhibitors. Now, I'm not going to say much about the AGIs. They're out there. They've been out there for a long time. Acarbose, amyclitol, very popular at one point in Europe, and one point in Germany. I think they were the #1 oral agent prescribed for diabetics. The problem with the AGIs, I think you're all aware of, is that these are probably the most flatulogenic substances known to man. I have yet to find a way of getting those drugs into people that they tolerate well, and for the most part, they aren't used all that much in this country, I think, because of the side effects. It's actually interesting, as I mentioned, in Germany, AGIs were tremendously popular at one point, and that either speaks to the German diet or to German tolerance, one of the two. But the AGIs we don't use all that much, at least in this country. But these are the various areas we can attack the hyperglycemia, at least physiologically. Now, a brief word about some of the medications. I think you're all familiar with the sulfonylureas. They basically flog the pancreas to produce insulin, more insulin. There is a little bit of data suggests that it might enhance insulin action peripherally, and they might lower hepatic glucose production a bit. But for the most part, these are the drugs that really hit the pancreas. Do they work? Yes, they work reasonably well. We're all comfortable with them. You can expect that probably half of your newly diagnosed diabetics with simple sulfonylurea alone are going to do reasonably well. However, a certain percentage will not respond. Either they're too far down the disease process, the beta cell's not capable of responding, or there just aren't enough beta cells there, but there are certain percentages that simply won't respond at all to the sulfonylureas. Metformin, standby. It's been available in Canada now since the mid-'80s, in this country I think since the mid to late 90s. A very good drug. Gives very good glucose control similar to sulfonylureas. It does not result in an increase in insulin. It sensitizes the liver to the insulin that's out there. Of all of the oral agents we have, this is the one that has probably the best effect in terms of weight and lipids. All of the other oral agents, particularly the sulfonylureas, usually cause a little bit of weight gain. We don't see that with metformin. If anything, weight tends to go down, and it's helpful from that standpoint. Because this drug is sensitizing the liver to insulins out there, hypoglycemia is rare. It can occur, but it's very uncommon. Most common side effects are related to the gut. If you start out at big doses too much, you're going to end up with abdominal distension, bloating, and some nausea. They are effective in combination therapies. I'll show you here in a few minutes. in terms of this business about lactic acidosis, it's very uncommon, and if you stick to the therapeutic guidelines that are put out there, you really won't have any trouble with lactic acidosis. You want to avoid it if the creatinine's elevated. You want to avoid it in patients with congestive heart failure or with liver disease. You want to stop it a day or two ahead of time if IV contrast agents are going to be used. Check a creatinine and start it after. But if you just pay attention to some simple therapeutic guidelines, lactic acidosis is pretty much a non-issue. Now, you will not see in this list age as a contraindication to use of metformin. It constantly amazes me the number of patients who are pulled off metformin in their 80s because they're too old for it. You know, if their heart's working well, their liver's working well, and their kidneys are working well, age is not a contraindication. You can use it quite safely in those individuals. But that's a little bit about metformin, a drug I think we're all becoming much, much more comfortable with. The TZDs, again, great drugs in theory, because a good part of the problem with hyperglycemia is insulin resistance peripherally, and the TZDs help enhance insulin sensitivity peripherally. The problems with these drugs are huge. Fluid retention and weight gain. Virtually every single one of them, except troglitazone, which is long since off the market, fluid retention and weight gain is a problem with them. You can't use them safely in liver disease or patients with heart failure. Rosie should absolutely be avoided. You need to sign a legal contract to use that stuff now. And pioglitazone or Actos, I'm guessing, Dr. Weird probably knows this better than I, will be off the market in the not too distant future because of the link to bladder cancer. And just last night when I was watching the news on TV, I see in New York City there were ads that if you have bladder cancer and are on Actos, call this lawyer. So it's coming. I think we're going to see the demise of the TZDs in the not too distant future. Now, how effective are these drugs at lowering A1C? And basically, when you look across the board, the sulfonylureas, the TZDs, metformin, acarbose, they will all lower A1C 0.5 to 1% in a research setting. Metformin has the advantage, it has the best effect on weight and LDL lowering. I won't go into that in any more detail. Sulfonylureas have a problem with hypoglycemia associated with them. But the moral of this story is that all non-insulin monotherapies are roughly equal. And that the oral agents, or older agents, there's a little bit of information that shows these actually might be even better than some of the newer agents. And I'll show you some cost concern issues here in just a minute. But basically, the monotherapies work. Doesn't matter which one you pick, they work, and they work reasonably well. Now, this is kind of a story where if one drug is good, is two better? And the answer to that is yes. We do have evidence that combination therapy is more effective in lowering that A1C than single agent therapy. And these are studies, there are several of them now. Pick your combination. Metformin plus TZD, sulfonylurea plus a TZD, metformin and sulfonylurea. If you add those together, you're going to get more bang for the buck than monotherapy. So we kind of are verging into this territory of starting out patients on combination therapy rather than monotherapy, much as it is with Dr. Basil talking about with the hypertension. But 2 is better than 1. Well, if 2 is better than 1, is 3 better than 2? If we add a third oral agent. And I'll stand up here and I'll state, and this is from practical experience, by the time you've got a patient on 3 oral agents, you have a confused patient. There are too many drugs out there, there are too many combinations, they can't keep them straight, and it's been my practical experience that if you're getting to the point where you're considering adding a third oral agent, unless you've really got a motivated and with it patient, it's easier just to add insulin at that point. Start out with 1 shot of insulin, keep them on the oral agents, and they generally do really well. But I've learned the hard way that 3 pills or 3 oral agents a day leads to confusion. So in terms of what combinations and when should we use, go back to this pathophysiology slide that I put up and think about what you're adding and why you're adding it. There was a question in the pretest came up about using glipizide and glyburide together. You know what? Those are both the same class of agents. It makes no sense to add in 2 of the same class of agents. And I see this over and over again. Patients that come in 2, sometimes 3 sulfonylureas, when 1 is going to look after the job quite nicely. If it's not looking after it, then you add in a different class of agent, be it the metformin at the level of the liver, add in a TZD, or add in one of these medications up here that I still have yet to comment on. So in terms of the approach, physiologically, when you're adding another drug, think of what you're adding and why you're adding it, and you won't go wrong. Now, what about these things called incretins? What are they? Where do we use them? Why do we use them? And I think primary care docs need to be aware of what incretins are. But basically, incretins are gut hormones that enhance insulin secretion in response to food. I'll come back to that point in a minute. The main incretin that's out there is GLP-1, glucagon-like peptide 1. It's produced actually in the distal small bowel and in the colon, and it rises within minutes of food ingestion. So obviously when you're eating and the GLP-1 level goes up, it's not because food is down there stimulating GLP-1. There are neural connections, there are other connections between the stomach and the distal small colon, or the distal small bowel, that leads to a rise in GLP-1. Now, GLP-1 is broken down by dipeptidyl peptidase 4. It's a ubiquitous enzyme that's found throughout the body, but one of the things that it does do is it breaks down GLP-1. So the half-life of GLP-1 is very short. It's only on the order of about 1.5 minutes, 2 minutes, and it's broken down very rapidly by DPP-4. Now, what does GLP-1 do physiologically? It does a number of different things. At the level of the CNS, it reduces appetite. Patients who have a rise in GLP-1 as a result of eating, they feel less hungry, and that's a direct effect neurologically. At the level of the stomach, GLP-1 delays gastric emptying. It keeps food in the stomach longer, causes stomach distension, and that secondarily can feed back to the CNS and reduces appetite, reduces food intake. At the level of the pancreas, GLP-1 does a lot. It increases insulin secretion, but it does it in a glucose-dependent manner. In other words, if your blood sugar is low and you give GLP-1, it's not going to induce insulin secretion because the glucose is already too low. If your blood sugar is elevated and you introduce GLP-1, then yes, insulin secretion will occur because the glucose is elevated. So one of the side benefits of these drugs is by themselves almost never will lead to hypoglycemia, because once that glucose comes down, the beta cell stops responding to the GLP-1. Where we see hypoglycemia with the GLP-1 analogs is when they're used in combination with other medications. I'll comment here in a minute. There's also a little bit of data that suggests that GLP-1 actually might enhance beta cell proliferation. We do see that in the animal model. So it's very tempting to speculate that maybe GLP-1 over time can enhance and repair that beta cell. The level of muscle, GLP-1 will increase insulin sensitivity. At the level of the liver, it actually reduces glucose production. It enhances insulin sensitivity at the level of the liver. I haven't put it on here, but there's some evidence and some evolving evidence that GLP-1 has a direct effect on the heart to improve heart function. That's actually being studied right now. So when you go back to our slide on pathophysiology, here's a hormone that does it all. It helps the pancreas, it helps the liver, it helps muscles peripherally. It basically does a little bit of everything. It reduces appetite, it reduces food intake, and at that end, kind of exciting in terms of how can we use this to manage diabetes, because here's a hormone that really does it all. Now, clinically, how can we use this hormone? We can give a GLP-1 analog. GLP-1, as I mentioned, has a very short half-life, and it's gone. But we can give an analog, of which there are 2 available, exenatide, Byetta, and liraglutide, the new kid on the block, Victoza. They work, and they work well because they have a long half-life. Exenatide's half-life, it needs to be taken twice a day. It's not long enough. Liraglutide, you only need to take that one once a day. There are new GLP-1 analogs coming around the bend, I'm told, that we can take perhaps once weekly or maybe even as little as once monthly. That's coming down the line. So one way we can get these effects is to give an analog, exenatide or liraglutide, or alternatively, we can prevent the breakdown of native GLP-1, and this is where the DPP-4 inhibitors kick in. Saxta, Sita, there's a new one out there I can't recall the name on. Basically, these drugs prevent DPP-4 from breaking down native GLP-1. Now, the problem with GLP-1 analogs is they need to be taken by injection. They're subcutaneous. Like any polypeptide hormone, they break down in the gut, so it's a bit of a nuisance to have to take it subcutaneously. You got to start at a low dose and work up, because otherwise patients get nauseated, they get abdominal pain, abdominal distension. If they've had pancreatitis, it's probably not a good idea to be using these, but you have to start fairly low and work up. I've learned clinically that the DPP-4 inhibitors, the Saxtas and the Citas of the world, now these are pills, they can be taken orally, but generally I haven't found them to be as effective as the exenatide or the liraglutides of the world. They just don't seem to work as well, and even though the literature and the science that's out there suggests that they work fairly well, I haven't seen that translate clinically. We have much more success with the GLP-1 analogs, with the Byetta and with the Victoza. Now, what are the long-term effects? How effective are these? There's some old data now. When you look at a study that's taken out over 80 weeks, patients on placebo or exenatide, at 30 weeks of placebo was switched over to exenatide, and you can see a nice lowering of the A1C. And this effect will stretch out for months to, as best we can tell right now, years. As long as they're on the drug, we see a largely permanent reduction in the A1C. It works fairly well. But what I find these drugs to be really exciting is the effect on weight. And again, here's the same study, and you can see these patients on placebo up here. At the end of 30 weeks, at the end of 6 months, were switched over to exenatide, and you can see the drop in weight. Whereas patients on the exenatide at the outset, their weight loss continues to go down. And this is actually a fairly effective way of losing weight. Are they approved for weight control? Absolutely not. We don't use them for that purpose. But where we found it to be helpful, the majority of type 2 diabetics, of course, are obese, and the GLP-1 analogs, I've learned, do help a lot with weight. Now, the GLP-1 analogs are approved for use in patients with metformin. Not a problem with hypoglycemia because metformin doesn't really lead to hypoglycemia. They're approved for use in patients on sulfonylureas. Here's where we see hypoglycemia. Combination of the GLP-1 analogs and sulfonylureas can lead to hypoglycemia, and we actually see that fairly frequently. And most recently, they've been approved for treatment in patients on insulin, which is really exciting to us. Up until recently, we couldn't, and we weren't supposed to use it in combination with insulin, but in a type 2 who's taking insulin, particularly a long-acting insulin, glargine, Levemir, you add this in, number one, you will see some weight usually coming down, but the big thing is their insulin needs sometimes will drop fairly considerably once they get on this medication. So if you got a patient taking perhaps an oral agent, they're taking one shot of, they're taking metformin and they're taking one shot of Lantus a day and needing 50 or 60 units of Lantus and they're still obese, if you add in Byetta or Victoza, it will help, should help with weight and it should help reduce their insulin needs, and this is what I've noticed clinically as well. Now, it's a nuisance because now you're introducing more injections than somebody already on an injection, but the patients we put it on have been pretty happy with it because of the effects that we see with them. So that's a little bit about the drugs we're using, a little bit about the new kid on the block, the incretins, the DPP-4 inhibitors, where they fit into the great scheme of things. What are our goals? What are we trying to do here in terms of managing diabetes? And it depends on who you listen to. The American Diabetes Association has its stated goals. The American Association of Clinical Endocrinologists has its stated goals. The ADA says strive for an A1C of less than 7. Once it's there, if they're stable, you only need to monitor this every 6 months or so. Those that are undergoing therapeutic change or who aren't stable, you want to check it every 3 months. The ADA highlights the need to control the blood pressure and the lipids. And why this is important, I'll come back to in a few minutes. ACE, on the other hand, suggests an A1C of less than 6.5, but basically they've tempered this by saying that we want to get glycemic goals as near normal as possible without hypoglycemia, because the flip side on all of this is hypoglycemia and the problems that come with hypoglycemia. So our goal is somewhere between 6.5 and 7% in the majority of diabetics. Now, this is tempered in the older individual, and the ADA came out and said this, that somebody who's older, 80, beyond, if they have multiple comorbid problems, an A1C of 8 or 8.5 is not unreasonable, because if you try and get an A1C of 7, you will create hypoglycemia, and that it's unacceptable in that age group. So you temper these goals with age and comorbid issues, basically common sense. And here's where we got the audience response thing, and hopefully I'll get this thing to work. I got to turn this on. It's a 48-year-old lady. It's only one that I have in here with a 2-year history of type 2. She's been on metformin at maximum doses. She's 5'6", 190. BMI is up a little bit. Blood pressure is good. Creatinine is good. Liver is good. Lipids are actually good. Her A1C is a little higher than you want to see. What are you going to add? In the list here, that should just be, I think your A, B, C, D, and E that you have there. I'm not sure. Yep. So if you just take ACAR both out, so you've got the top 5, what are you going to add? Okay, here's what we got. A third of you said exenatide and sulfonylurea, it looks like, and the rest were kind of scattered with smaller numbers in between. This is kind of a fun question, because the reason it's a fun question is there's no clearly right or wrong answer. Any answer that you put up here is going to be correct, including acarbose, if you wanted to put that one up. But it's interesting, I think, and it shows the level of audience comfort with something like sulfonylureas, which are drugs that you've all used and used for some time. But there's no clearly right or wrong answer, and I'll show you why here next. The ADA, in conjunction with the European Association for Study of Diabetes, came out with kind of a treatise, I guess, of sorts, medical management of hyperglycemia and diabetes. And this is a consensus algorithm put together by these two groups. And this is that algorithm. Now, I find this very confusing. It's difficult to look at. Basically, at the diagnosis, you start out with lifestyle and metformin right from the get-go, and that I do agree with. If that's not working, then we go to adding in basal insulin, or perhaps we can take this too and add in a sulfonylurea. That would be, go to step 2, less well-validated therapies. You can add in perhaps pioglitazone, perhaps a GLP-1 analog. If that's not working, you can go over here to the third column and add in intensive insulin therapy or pio or sulfonylurea in addition to metformin. Basically, it's a complicated way of looking at things when intuitively, this is what you're probably going to do anyway. And over here on the sideline, they say you want to aim for an A1C of less than 7%. You want to avoid some agents, particularly chloropropamide. But this is a complicated way of looking at the problem, and I find very confusing. So how do I rearrange those words and come up with something that most of us are currently doing, and I suspect most in the audience are currently doing right now, is that once diagnosed, patient is sent for lifestyle change monitoring, basically education from the diabetes educator, and it really depends on what their level of blood sugar is, what you're going to start. If they're hyperglycemic crisis, ketoacidosis, or if they're pregnant, or if their blood sugar is unequivocally elevated with symptoms, that's a no-brainer. You're going to start these people on insulin. There's no point in fussing with all of these other oral agents. On the other hand, if their fasting blood sugar is maybe 180 or so, random blood sugar is 250, or A1C is 6.8, 6.9, a little bit above, you might just want to attempt lifestyle alone without any intervention. But the majority of what you're going to see at the outset are going to be right here, right in this group. They're asymptomatic for the most part. The blood sugars are a little high. And there, you're going to start metformin. And this is what the ADA recommends, and I agree with entirely, and I think most of us agree with. At the time of the diagnosis, if they're otherwise doing well, there's no contraindications, blood sugars in this range, start metformin. There's no reason why you can't. It's safe. It'll help from the weight standpoint. Now, in terms of taking a stepwise approach, what do we do next then? Lifestyle modification in addition to the monotherapy are kind of rolled together as one. If that's not effective in terms of getting you to goal, combination therapy with oral agents usually would be the next step down. There's the evolving thought that maybe we should start with combination therapy at the get-go in patients. That still, I think, is out there. There are numerous studies that suggest that might be a very good approach. It's like the story that Dr. Basil showed you with hypertension, is that maybe right from the get-go we should be thinking combination therapy. If combination therapy isn't working, you step up to insulin. You either add in insulin to oral agents, or you stop an oral agent, add insulin, or you simply abandon oral agents and go straight over to insulin. If insulin once or twice daily is not doing it, step up to multiple daily injections or consider an insulin pump. That's beyond the scope of what I want to talk about here. But there's some important issues here. Expect over time you'll have to intensify therapy. The natural history. What happens with it is that things get worse over time. So expect you will have to step up to 2 medications and sooner or later add insulin. Don't sit on our rear ends and do nothing. And I see this over and over and over again. Clinical inertia is that patients and physicians are reluctant to make changes. We need to make changes if we're going to make a difference in that patient over the long term. When adding oral agents, as I've shown you before, consider what class you want to add and where you're adding it. And rather than add in another on the same class, go to a different class, add in, think about why you're doing that. And make significant changes. If you're going to start an individual on insulin, starting them out on 5 or 6 units of Lantus insulin a night isn't going to work. You want to start these patients, if they're obese, on 30 or 40 units of Lantus a night in addition to their oral agents. So make significant changes. Don't go from metformin 250 milligrams once a day to metformin 250 milligrams twice a day. It's not going to work. So when you're stepping up, step up and make those changes as rapidly as you need to get that patient to the goal that you and the patient have decided is best for that individual. Now, part of this equation is going to be cost. And I went to our pharmacy back earlier this year, and I just said, here are the list of the medications, the oral medications and GLP-1s that are out there. I want to know what they cost, and these are the standard doses that we're going to be using per month, if this was out of patient pocket. And the numbers here are staggering. If you look at good old glipizide, 10 milligrams twice a day, fairly common dose, you're looking at $15, $16 a month. Whereas if you go to something like Victoza, you're over $300 a month. Now, as far as I know, and Dr. Weir maybe knows better than I on this one, I'm not aware of a single study that shows that any one of these drugs is clearly superior to another in terms of managing diabetes and its complications over time. So when you're talking to that patient, all of these drugs have side effects. They all have their benefit profiles associated with them. They all have things that we want them to do for us. What is that patient able to afford? Is this going to work or not? And of course, in amongst all that, we've got the insurance companies we fight with as well. But this is kind of an eye-opener in terms of what the costs really are to that particular patient. And some of these costs are staggering. So yeah, the exenatides and the liraglutides of the world are good in terms of what they do physiologically, and they make good sense. They also cost a fortune. So going back to that consensus algorithm by the ADA, the A1C should be as close to normal as safely possible, and a level of over 7 is a signal to change if your goal is less than 7, and this is not appropriate or practical for some. And again, I highlight clinical judgment creeps in here. Somebody in their 70s, 80s, 90s with multiple comorbid problems, an A1C of 7 is not going to be tenable. There's no evidence that that's going to help that patient in the long term, and an A1C there of 8 or 8.5 and avoiding hypoglycemia is probably quite real, or quite acceptable. You want to avoid hypoglycemia. We need to treat cardiovascular risk factors, and I'll show you why here in just a moment. At the outset, the majority of patients now, we're starting with lifestyle modification, education, and metformin if there's no contraindications. Rosie is out. That one absolutely should not be used. A question that comes up, if a patient's already on Actos, should we stop it? No. If they're doing well on their Actos, there's no reason that you have to switch it at this point. We switch it if they're not doing well. That's the therapy approach to therapy in terms of diabetes. I now want to go over, for the next few minutes, some update and information on complications of diabetes and why we're doing all of this therapy is, of course, to prevent the complications or from occurring or slow them down once they're on board. And when you look at kind of the whole realm of complications of diabetes, and this is just kind of a broad paintbrush view on complications. We've got macrovascular complications, coronary disease, peripheral vascular disease, cerebral disease. We've got microvascular involving the eyes and the kidneys. We've got neuropathic complications, of which there are many. All of these come together, of course, at the level of the foot and lead frequently to ulcer, amputation, and that's a combination of all of the above problems. The goal of treatment in managing diabetes, of course, is to prevent or delay the onset of the diabetic complications, or if the complications are present, we want to delay, prevent them from getting worse. That's why we're doing all of this in terms of managing diabetics. Having said all of that, it's not peripheral neuropathy, it's not the eyes, it's not the kidneys that kill diabetics, it's macrovascular disease. By far, the majority of type 2 diabetics, what kills them is the macrovascular disease, coronary disease. 70% of all deaths from type 2 diabetes related to coronary. The risk of an MI in a diabetic is equal to the risk of an MI in a patient who has already had an MI. So the risk is clearly there. Dyslipidemia, hypertension therapy is mandatory in this. I'll show you why. Coronary disease in the diabetic can present in all sorts of weird and wonderful fashions. Reflux symptoms, jaw pain, many of them are asymptomatic. You do an ECG 1 year and an ECG a year later, and there's a new infarct. The patient didn't even know it. They've got peripheral neuropathy. They're not able to feel, or got aneuropathy. They're not able to feel their chest pain. So they can present in all sorts of weird and wonderful ways, including sudden onset of congestive heart failure as a manifestation of their heart attack. Many times in the office when I'm seeing a patient who calls me up and says, "Doc, I'm feeling well, but my blood sugar just went from 100 to 250 and I can't get it under control," run an ECG on them, and lo and behold, there may be a new MI there. Now, the impact of tight control of diabetes is unclear, as I'll show you, when it relates to macrovascular disease. So that kind of leads to the issue then, I've been saying throughout all of this, is that we want to control diabetes, we want to prevent this from happening, but what is the evidence that as it relates to macrovascular disease, that better control is better? And this is kind of an interesting history lesson. And we go back then to the DCCT. I told you I wasn't going to talk about type 1s, but the DCCT, of course, is type 1, which kind of defined the standard of management. It came out in the early 90s for type 1s. These were 1,400 type 1s randomized to really tight insulin control versus conventional therapy back in the early 90s. We followed it up for 6.5 years, and the complications were looked at. The A1C was different. It wasn't much. It was only about a percentage and a half point, 2 points difference between those that were intensively controlled versus those that were regularly controlled. But it made a difference. These patients had much less retinopathy, much less nephropathy. They had much less neuropathy. So overall, they seemed to do better. But interestingly, the tight glucose control did not reduce a risk of cardiovascular events. They still had their MIs. And we thought, well, you know what, this is a young population. Maybe it's just that they're too young. They haven't had their diabetes long enough. Who knows? But whatever it is, we're not going to pay attention to that. Retinopathy, neuropathy, and nephropathy were clearly improved. Roll the clock up to the mid-90s, a little bit beyond that, 96 now. The UK PDS came out, same sort of study in patients with type 2 diabetes mellitus. And these were newly diagnosed. There were 4,000 of them, intensified to, or treated, randomized to tight control versus standard control. The A1C was lower. Here's what we saw in terms of their complications. Microvascular disease improved. Diabetic retinopathy improved. Microalbuminuria improved. MI not improved, 0.052. We looked at that and said, gosh, these patients are having their heart attacks. Our tight control hasn't made much difference to the heart attack. And again, we kind of blew this off saying, oh, they're newly diagnosed. They're kind of a younger patient. They haven't had their diabetes long enough. Whatever. It was close to statistical significant. A couple of patients either way made this less than 0.05. But it was kind of an interesting, because what UK PDS showed us was what the DCCT showed us. This is in the mid-90s. Those are the good old days, because we still patted ourselves in the back and thought that we were helping diabetics from the macrovascular standpoint. Then along came these two studies that kind of rocked our world, which were ACCORD and ADVANCE, and I put the acronyms up there for those of you that can remember that kind of stuff. And these were big studies. ACCORD was conducted in the US and Canada. ADVANCE was global. Thousands of patients randomized to, again, intensive therapy versus standard therapy. And now we're looking at age groups that's applicable to what we're seeing in the population. Diabetes in the older age group, in people in their 60s. They were followed for 3.5 years in ACCORD. That study was stopped for reasons I'll show you in a moment. In ADVANCE for 5 years, and the endpoints were basically those of macrovascular disease. Now, how did it all sort out? When you look at the studies, these are they. The median A1C was improved in those patients on the intensified arm. However, when you look at death from cardiovascular disease in the ACCORD study, it was actually higher in those who had intensive control. This is why the study was stopped early, was because these people were dying sooner than they should be. When you look at hypoglycemia, much higher in patients intensively controlled, as you would predict, and maybe it's the hypoglycemia that was leading to their heart attacks. They also tended to gain weight. Again, by virtue of intensifying their control, their weight did go up. And we saw the same sort of thing with regards to the ADVANCE study. The death from cardiovascular disease wasn't higher, but it didn't significantly improve. And hypoglycemia, again, was a bit of an issue. So these two studies led us to the conclusion that intensive management of glucose in type 2 diabetes by itself does not improve cardiovascular endpoints. Very, very disturbing when it came out, and it really did rock the endocrine world. And then, of course, we had even more depressing news a year later when the VA diabetes trial came out and showed much the same sort of thing in a VA patient. 1,800 patients. Now, these are patients who many of them already had diabetes. Some of them were new, randomized to intensive versus standard therapy. Again, the age group you're seeing in the office. The primary endpoints are there. They were followed for 5.5 years. And the results here were equally disturbing. The A1C did improve on those ones we tightly controlled, but we had no difference in any component of primary outcome at the rate of death, and no difference in terms of microvascular. This is the only one that said the microvascular disease didn't improve. But more importantly, the macrovascular disease, again, tight control, did not translate to reduced macrovascular disease, and hypoglycemia remains a big problem in those who are intensively controlled. So the VADT came out and said much the same sort of thing as it related to macrovascular disease. So now, 2010, 2011, we have 5 studies that are all saying much the same sort of thing. The original 2, we've got the Accord, we've got the Advance, and we've got the VADT, all saying that cardiovascular endpoints don't seem to be improved when we tightly control that patient. And this has been kind of disturbing. It's kind of been a little bit mind-boggling, as it were. There was a great editorial on this whole issue that was published by my good friend Victor Montori out of Rochester. It was published in Annals of Internal Medicine, Glycemic Control in Type 2 Diabetes, Time for an Evidence-Based About Face. And it started out with this: when the facts change, I change my mind. What do you do, sir? So we need to be looking at what we're doing. Now, how can I reconcile this? How can I come up here and say, we got to get these folks under control, and here's the reasons why, and on and on and on, when I've just shown you 5 studies that suggest that improving them doesn't help what kills diabetics. There is a study we can go back to that will help focus this picture better. It's an old one now, and it's small, but it's very enlightening. It's something called the Steno-2 study. This was an 8-year study of only 160 patients with type 2, randomized to tight versus conventional control. But in addition, other risk factors were tightly controlled. Blood pressure, lipids, they were all started on aspirin. All of these other things that we're supposed to be doing were controlled in the Steno-2 study. Their A1C was chased after, their lipids were chased after, their blood pressures were chased after, they were put on ACE inhibitors, aspirin was added, and several endpoints were looked at in this particular study, which was published in 03. And when you look at the conventionally treated therapy versus the intensive therapy, there is a huge difference. The death rate is much lower in the intensive group. The cardiovascular death rate is significantly reduced. MIs were reduced, strokes were reduced, all cardiovascular events were reduced. So Steno-2 is giving us a lot of information that kind of bucks what Accord and Advance were telling us. They also noted reduction in microvascular disease, which I won't go into, and this is just a curve showing the effect, and you look at primary composite, all endpoints, what happened with these individuals. So Steno-2 told us, don't forget about other risk factors: blood pressure, lipids, smoking. Get these patients exercising. Start them on aspirin, start them on statins. This study came out long before Accord and Advance did, and yet it didn't get a lot of press because it's too hard to look after all of these things together. But it did demonstrate that if you do it, we're going to have a good result, whereas Accord and Advance, which didn't pay as much attention to other risk factors, didn't show the effect. And the caveat of this is that there's a whole lot more to a patient than sugar alone. And I can't highlight enough what Dr. Basil said about hypertension, and I want to throw in a bit about the lipids as well in terms of making a difference from the macrovascular endpoint. I think a better control better. Kind of what I conclude here is that the overwhelming evidence would suggest that the ADA and ACE A1C goals are probably reasonable as it relates to microvascular and neuropathic disease. But when we're looking at what kills diabetics, we have to pay attention to lipids, blood pressure, aspirin, and this now really needs to become our standard of care. We need to embrace those other risk factors much more vigorously than we have. From the diabetes standpoint, the tools are available to get that blood sugar down where you want it, wherever you set your goal. The tools are easily available. We now need to roll in blood pressure and lipids. So to do this, this is basically a common sense type of slide. We need to prioritize patients to a healthy lifestyle. We need to highlight preventive care, go after cardiovascular risk factors. Rolled into this, you have to have a patient. Consider the cost burden. What are you going to start that patient on, and what reason are you starting it? What is the risk of hypoglycemia? I'm going to accept hypoglycemia in a 50-year-old who's asymptomatic much more than I'm going to accept it in an 80-year-old. Weight gain. We need to be cautious with the weight gain, particularly important in younger individuals. And the A1C target needs to be individualized. There's no one target that fits everybody. But the majority, the ADA recommendation of less than 7% is probably appropriate. So how do I summarize all of this? Diabetes prevalence and costs are skyrocketing and really going to take off, particularly as some of the larger countries, India, China, become more industrialized. The importance of diet input and diet follow-up over time. We take a stepwise approach beginning with lifestyle, and the majority of them we're going to start with metformin right from the get-go and rapidly step up to achieve the goal that you're aiming for. Consider what you want to add in terms of the pathophysiology. Don't add in 2 drugs from the same class. You're not going to achieve anything. There's clear evidence that better control improves the patient from the microvascular and neuropathic standpoint, The macrovascular disease may not be impacted with if all you're treating is the glucose alone. You need to treat the comorbid problems and be equally vigorous. You need to individualize these goals. There's, again, no one size fits all, and that we're becoming aware of. And in the past, we used to think one size fits all, everybody has to do the same thing. Not necessarily true.